Let's get started. So, welcome everybody. It is May 2nd. It's another Friday, and we're very honored today to have an amazing guest. We're kind of continuing the theme here of surgical airway. And interestingly, after the last webinar, I actually bought that little Cricolot uh, tool, and maybe Alan will talk about that today, but something very interesting for all of us as we start to consider how we train our folks on certain procedures that are high acuity and low occurrence. So today we have someone that I met at NAMSP. He's out of the Denver metro area. He's a paramedic. He's a trainer. And Alan, I'll have you do a further introduction of yourself. But when I heard this topic, when we spoke, I said, "Hey, you got to come on the webinar," and we're excited to hear what you have. You have in front of you a group of EMS professionals, leaders, medical directors from all over the country. We have people from the state of Florida, Department of Health on I see today. So you have a great audience, and we have a big audience on LinkedIn and YouTube. So, my friend, thank you so much for coming on and take it away.
Dr. Intevi, thank you for having me on here. My name is Alan Kennedy. Like Dr. Intevi was saying, paramedic out of the Denver metro area. I've been lucky to work on several government contracts. I bounce overseas from time to time, either in a training capacity or a clinical capacity. So I've been able to work with different pre-hospital audiences. And through all that, I've kind of found this is what works for us. It's not saying this is the way, this is just the way that I have found that has good repeat success from people I see maybe once a year or anything like that. It's not meant as a train the trainer. It's not meant as a, hey, this is how you should crike. This is just, like I said, this is what the path is that I have found that works decently well or works really well with the audiences that I'm a part of. I do have one disclosure. The wearable moulage, I work with the guy that makes it, but as an end user, I love it, and that's kind of what's helped me with the Christ that I've had. For sniff test, I've had two solo and then two assisted. And then in reference to Dr. Patrick and Dr. Lula's, one was trismus and one was severe trauma to the face. So I kind of line up anecdotally with what they were seeing for their system also. But moving forward, as my computer's yelling at me. Okay, so this is pretty much how we frame stuff, or I frame things with the training. It's based off the stress exposure training model by Driscoll and Johnston. And it's pretty much broken down into three phases: information, skill acquisition, and then application and practice. Walk, which is phase two, the skill acquisition side is the most important part. And what I have found is doing dry marker drills, or if you're someone that is into firearms, like dry fire drills, that's where the biggest bang for the buck for me has been, because it's people developing that muscle memory and developing the skill from there. And if you get more complex patients, you have a framework to start from versus just looking at them going, oh my God, and you don't want any part of this whatsoever. If you're a training nerd like I am, you got two papers listed below. One is by John McCarthy, Andy Fisher, and Mike Loria, and it does a great job discussing stress exposure training, cognitive load theory, deliberate practice concepts, and sim zones. And then another one is by I think it's Colonel Mueller, and it was from a study they did RCT where it's pretty much breaking down choose your own adventure versus a very structured, didactic anatomy, and then hands-on skills where it's very step focused of scalpel finger bougie and how their success was with that training method. For this, going back one. So like I was saying, for the crawl phase, psychology, anatomy, equipment, technique, explanation, what you can expect of the patient. It's like the gurgle, gurgle, stuff like that. And then what does right look like? What does that demo look like for your audience? Moving into that, that's where, like I was saying, this phase two is the most important part. What does right look like? And then you start working through hands-on drills. If you have large classes, this works great because you're getting your hands on maybe 10, 20 different sets of anatomy for free. And that's a really easy, low-cost thing with just expo markers. And then models, whatever it's 3D larynxes, moulage, whatever the case may be. And then from there, scenarios. And then that's the case where it might be a distressed patient, but you're never looking for like the end of the world scenario and, oh man, we got them good. You want building success from a no stress environment to one little stressor, two little stressors. And if they're accommodating to that, then you can add to it. If not, hey, just hang out right there for that person. Moving on to psychology, this is one of those things that everyone talks about. And I think this is where it's also very important, probably one of the most important parts of it. And as discussed last time with the recent webinar with that. First is that mindset, removing the negative language, replace it with having a plan. Because if you're saying, I hope I never have to do this, you're already going into it kind of self-defeated versus, okay, if I ever come to this place, I have a plan or at least a place to start with it. Transitioning to that, like what my plan is and the way my system works, it's intubation, eye gel, crike. Not saying I'm looking to go crike someone. I have that as part of my decision tree in case it comes to that point either immediately, like it was discussed previously, or if it's something that works to that direction. For this, good opportunities for building that tactile feedback. If you're on airway for a cardiac arrest, when you're doing that pre-ox period and you got your equipment out, hey, take a second, feel that person's neck. Probably not going to happen, but you at least got an idea of what the landscape is moving forward with that patient if it does come to that. Same thing for anaphylactic patients, like severe anaphylaxis or anything like that. It's, hey, after you do all the appropriate treatments or anything you need to do, hey, also feel their neck. Have an idea what that landscape's looking like. So if you do end up in that position, it's not you reacting to something, it's more of a response. Next, tactile skill. This is one of those things that I heard and I understood the words being said, but I didn't understand what they meant. And the last one that I had is actually ejection side of the road, middle of the night, and that's where it clicked for me, where it's a tactile skill and not a visual skill because it's going to be bloody and all this other stuff. And at the end of the day, it's kind of like where you're feeling IVs blind, where it's not you're just looking for the vein. You're feeling for the landmarks and the anatomy that you need to make that procedure happen. And then finally, stole this from Scotty Bolliger, don't convince yourself, give yourself permission to work. The easiest way I equate this for pre-hospital is the first time you see SVT and you know you should give adenosine, but you're kind of convincing yourself, are they good to make it to the hospital? Go ahead and do it. And as you move forward in your career, it's like, okay, cool. We got SVT. Here's my plan, how we're working through this. Tanner, I apologize for this slide. It's kind of a muddle of two different papers, but everyone has their anatomy slides. This is the one that I feel like is kind of lacking, and it also helps prepare someone for that procedure as well. So what you're looking at, you got the CTM circled in the red right here. And then from these two papers by Nutbeam and Kukulu, I think, the mean neutral male CTM height is approximately 7.21 to 7.88 millimeters. For context of this, the usual ET tubes that we use are 6.0, which means it's an 8.0 diameter on the outside. For women, the mean neutral female CTM height is 6.41. And you got the different age groups broken up. This lower table for both come from the Nutbeam paper. The 7.21 to 7.88 is a combination of the findings from both papers. So again, Tanner, sorry about that one. It's kind of a jumble, but this is kind of how I capture it. But the important part also from Nutbeam's paper is the height of the CTM may increase approximately 20% with maximal head extension and maximal dilation and mobility of the cricothyroid joint. So if you want to play along, put your finger on your CTM and then neutral position and kind of put a little more pressure on than you usually would, and then tilt your head back and you feel you get more real estate. So if you got some of these patients that might have a tight CTM, this is something where I'm advocate for going from the cartilaginous borders of the CTM because doing that you can buy yourself more real estate, and that's also I ran into the last one. The last one that I had was a 17-year-old, and that's one where I was able to be aware and talk myself through that. This is just a reference table for anyone that wants it. It's based off the Curaplex ET tubes, and it's just showing the outside diameter in comparison to internal diameters, length, and some of the bougie sizes that are compatible. So it might be a case of, hey, your system discusses 5.5 or 5.0 tubes because of the anatomy differences that people see. If you're a bougie system, then what you have might not work. And that's the only reason why I have this here. Paper below that kind of analyzes 21 devices, the NAR stuff, like I believe Dr. Miramontes has talked about, where it's more the Shiley style. Those aren't covered in there. Moving on to kind of what training technique and the lecture and demo side looks like for us, modeling best practice. What does right look like? Again, I'm a scalpel, finger bougie, and modified laryngeal like handshake kind of person. I prefer starting from sternal notch and moving my way up because male or female, there's no mental anchoring to the Adam's apple that way. So you get consistent anatomy across any patient you're getting your hands on. Model basic maneuvers prior to performing surgical airway. If this is something where your organization, whether it's DOD, hey, you want them in the recovery position first, or if you're in a system, say, hey, try iGel first, don't just jump to it if it's not absolutely appropriate. Figure out what works in the interim. And if you don't need to cut them, that's awesome. And then finally, kind of illustrating dangers and need to stick to the plan. Um, don't put your patient or don't put your equipment on your patient. You either can have stuff knocked off or depending on the situation, again, environment, what audience you are, they might knock it off themselves. We like to say cartilage to cartilage. So, or as some people cue it as like maybe 2 or 3 fingers width right here. And then considering distorted anatomy, this is one where again, have the conversation. So if someone runs into it, is not this new concept in front of them. Technique, kind of like what we're talking about. I like the modified laryngeal, I can't say the word right now, handshake. And for me, instead of saying fingers 1 and 3, I'll just call it the snapping fingers because everyone knows what that means. And then from there, I'll kind of make sure everything's in line. Finger at sternal notch, come up, palpate. At this point, you kind of feel that like that box right there. So I'm locked into here. I can palpate. Hand stays married to this, finger out of the way, go through the procedure. I'm a fan of putting the forearm on the sternum for stabilization. Hands still shaky when I've done them, and I talk about this stuff all the time, so I like having that platform. When in doubt, I think this is more for the bariatric patients. If you're getting your finger in there and you can't really find the landmarks, find that thyroid cartilage. And if you can find the lamina, which are like the wings for the larynx, if you can find that, you can find the membrane easily. It's a reference that's always there. And then I'm a fan of doing the bougie behind the pad of the finger or along the side of your finger. In training with cadavers, I've seen where the bougie has gone over the finger, dissected tissue. I've kind of seen that with some of the NAR, the Shiley style kits too. But I'm a huge fan of that tactile feedback of having your finger in that space, getting the bougie behind it, and you know you're there. Going on to this, what I feel is the most important part, or what I've seen for a lot of success for people moving forward, where I might see them once or twice a year. Dry erase drills or dry fire drills, get the reps in on different anatomy. So if you're on a fire crew, you got 5 different sets of anatomy for maybe $2 to get your hands on. At this point, there's no distractions, no stressors or anything like that. You're simply just hammering that external tactile feedback skill and building that muscle memory of making that vertical cut, making that horizontal cut, finger back in, plunge cut, moving from there. Finger not in the space when you're doing the plunge cut. Again, depending on the audience, if you're SWAT, DOD, or anything like that, this is all where you also have the case of you're doing the procedure on the teammate you might be doing this procedure on. So you're kind of reducing that mental hurdle because you've already been in that place with them. Same thing for depending on the situation. If there are awake crikes out there, or just a lot of ketamine on board, depending on the environment, you might have a person looking at you or close to it. So that's also something from the psychological benefits. You're doing this procedure where this won't be the first time you're in that position if you have to do it. The way I like to run it is if you want to visually associate with what you're doing, totally fine. I like that in the very beginning, but I want people moving towards having it just to feel versus visual and feel. So then it's like when you get the different reps and different anatomy and all that stuff, you kind of already have that baseline, like again, like you would say for some IVs. And that way you can work through it and say, okay, I know what this feels like. and you're not super task saturated visually. There we go. This is kind of just a short, if someone wants to take a picture of the slide or anything for their own benefit, awesome. I'm not going to talk through the whole thing. But the one thing I will say, what I've seen from trainings, one of the groups that we train, we have nursing students as role players, and we're able to get the dry marker drills with them every day for the week that we have them. And the confidence and success rate moving forward through various classes with them accelerates exponentially and very noticeably. Don't have that quantified like with a paper or anything. So I'm just a guy telling you a story right now. But if you have females available for this drill, it is absolutely amazing and critical if you can get them incorporated into doing these drills because again, that's where you usually see people getting hung up, and that's usually where the problems are. And if you kind of crush that doubt or no, lack of confidence, that's a great thing, or they are a great group of people to incorporate into these trainings. Looking at low cost and free 3D tracheas, the picture, this guy right here, 2-inch tape over it. What I have here is images from Chong. We'll have a link to a Google Drive at the end of this that has a walkthrough for all of how he does stuff, but different ways of doing it. You can throw an ace bandage over it, tape it down to simulate skin. You can do 4x4s. What he's done for a bleeder is he'll do fake blood in like a tip of a glove, fingertip of a glove, and throw Coban over that. And then what you see on the picture on the right, he'll run IV tubing to that glove, throw a 10 cc on the back end, so that way you can get some of that gurgle or sputtering with it. And again, it's not going to cost you much at all. Next, pig tracheas. I'm not much of a fan of these, but I do acknowledge they can have some training value. Um, Usually you'll see them wrapped in Coban. It's just not like this, how you see in the images. But one of the grievances I have with it is we train and we talk human anatomy, but when we go to actually doing the rep on something, it's completely different anatomy. The tissue's thicker, the membranes are a little bit more difficult. As you can kind of see in the pictures, like down here, if you see my mouse, the CTM is more of a V shape than that oval shape like we have. So I think that's where, if you work with pig tracheas or anything along those lines, you usually end up with a trach for that reason, because we're cueing for this, but for them, they're looking for more of a V shape. Um, Also, I've seen this mentioned in other places. I've had the same experience. That cricothyroid space can be difficult inserting the tube, even with a bougie. This is the one that I was saying I do have a disclosure for. This is SMRT, Surgical Airway Trainer. I love this thing. This is kind of what's helped me a lot, and it's kind of helped bridge that gap for other people from doing dry erase drills to moulage, then moving on to cadaver, whatever advanced training models you might have. But this thing I love, I saw it mentioned in the previous podcast, so if or webinar. So if guys are interested in it, I love this. If you're going to be at SOMA this year, he'll probably be down on the trade floor also. So if you want to get hands-on or anything, chat shop with him. Um, Here's mine right here. Moving on to more of the high cost stuff, you have cadaver. Usually you'll see fresh or frozen. Pros, obviously more realistic. There's a variety of anatomy. You can have kyphosis, you can have bariatric, you can have younger, older, anything like that. Sometimes I've seen with the frozen where the chest might still be cold, it'll tug the trachea down a little bit more. So you don't have a great realistic reference point. However, it does help you work through the problem with the patient you have in front of you. Cons, unless you're in a place that has the cadaver hookup pretty much, they're typically expensive. And then you only get one person that really gets that full true rep. The solution that I have found for this, and I'd love to see if anyone's doing anything different and what works for them. Um, I'll call it segmenting it out. It'll be like, hey, Tanner, you're the guy doing the procedure. I'll let everyone know Tanner's doing the procedure and say, hey, we're going to break this down into different phases. So while Tanner's prepping the kit, I'll have everyone palp the CTM. Then Tanner will come in. He'll do the same thing, make the cuts. finger in, palpate the membrane, and then I want them to go from the membrane to the lamina to finding the membrane from there. Because again, if you have a patient where it's hard finding the landmarks, if you can find the lamina, you're in a great spot and you can find the membrane from there typically. From there, Tanner will step back. Everyone feels the lamina to the membrane. At this point, you can do like a 10 cc flush, add some fake blood. So you're kind of removing that visual cue now. And then the person finishes the full procedure. And what I've seen for this is it's doing the whole thing, including securement, because again, guys are building that muscle memory still if they're new to it. And if you don't make them finish the whole thing, even securement, they'll leave it alone on scenarios. So make sure they're doing the full procedure. And then this is also an opportunity to manipulate the head to see the CTM height changes. So again, cut to both borders, and then even just extending and flexing the head, you can see how much that thing moves. Moving on to training techniques and run, this is where I was saying, hey, you start simple from low stress, nothing crazy. It's not the end of the world. It's not this crazy MCI where people just walk away saying, what just happened versus I learned A, B, C, D. Um, just add one factor. Is it a stressed patient? Is it a time sensitive thing? Are there distractions? And then progress with those if you have time. And then that's going to be like impractical positions, noise, light, or lack of light, or anything like that. And then finally, not finally, but you can introduce, or I do encourage introducing scenarios where you're tempting the provider to do a crike, but it's not necessary for that patient. So again, not looking for a hammer and nail solution, but working through a clinical mindset of, hey, does this work? Is this what I'm needing? Or do I need to go straight to this now for reasons A, B, C, D? Make that clinical decision versus just reacting to something. Tracking failures and remediate aggressively. This is where I usually see the hands dancing. And like I say, the snapping fingers, that's one that I've seen a lot too, where I understand the words, but I don't internalize it. But once people understand that, that's when they're like, oh, okay, this makes sense and can repeat it. So that's usually the thing that I remediate immediately. It's positioning. And again, this is more pre-hospital. It's not, hey, we're in a closed environment where we're sterile, we're controlled, or anything like that, where you do have more latitude to move around. This is for the guy that might do this once in a career, twice in a career, wherever the case may be, and just building that muscle memory and that habit to come back to something that works for both sexes and is easily repeatable. I think that basically covers it. Excited about the conversation. If I blew through something, ask me a question about that, and that's it. There we go. So here's contact for me. Here's the Google Drive, QR, and a Bitly. I did check the Bitly this morning, so it should work. It has videos on there. It has Chong's walkthrough of how to make the trainer with the balloon or the bleeder or anything like that. So if you're looking for low cost options, he has a complete walkthrough on there. I can go back to the slide with his Instagram if he's something you want to reach out to and you have questions. That's another option, and I cleared that with him also. And I think that's it. Hopefully, I didn't burn too much time with that.
No, that's perfect. Alan, no, it's perfect. We have plenty of time for a Q&A. I see Dr. Pepe has joined us earlier. Dr. Pepe, how are you?
So far, so good. Emphasis on the so far part, right? So,
Okay.
hey, is it okay if I make a couple of comments?
That's why I wanted to bring
Absolutely,
you in.
sir.
Yes.
Oh, so this is great. One thing, and I really want to digress. Not, I don't know. I would say spin off from what you said, which is you think about what's going to happen ahead of time. And one of the things I think that maybe you said it, I just maybe didn't hear it, but is anticipate what could go wrong. Okay, that has to be done ahead of time, so you're prepared to do that. That I mean, it's kind of a corollary to what you were saying before about not, am I really slow? Oh, here we go. About preparing for it ahead of time, and so when you take them through it, what are you going to do if it goes wrong? And that gives you more confidence, and also you do better as a result. So that's always been part of the training and so on. And by the way, of the ones that I've done here, I always find that the medics are always like better skill set wise in terms of motor skills and all that over the years. But one thing we ended up doing one time, and we published it, was we saved a police officer's life. He had actually been shot through the cricothyroid area, and he was bleeding and asphyxiating too. So we actually had to go with the local trach. But fortunately, we were SWAT docs. We were there. But anyways, but it's still the main thing was I really liked this and what you did and presented it, and especially the concept of thinking ahead and putting them in that position before they first do it. It's not just training them a procedure. I think that actually applies to almost any procedure, right? And the tracheal tubes, whatever it might be. So, okay. But thank you. Great job.
Thank you,
Excellent.
sir. I did allude to that. I didn't outright say that. That's kind of like my dancing example. So, no, you're totally right. I didn't outright say it, but I did allude to it a little bit here and there.
Excellent. Let me go to Dr. Ingram, and then we have someone joining us right now who's been on LinkedIn, pinging on LinkedIn, and I said join us on the Zoom. So Jacob, I'm going to bring you in next. Let me go to Dr. Ingram first.
Yeah, awesome. Sorry, my voice is a little messed up today, but awesome presentation. Much appreciated. As probably the most recent surgical airway in this group, as mine was in the last week. I love the topic. Luckily had trained again and again and again, and most recently like 6 months ago. So felt very comfortable. And exactly what Paul is saying, things go wrong. Like when you are most prepared, things still go wrong, right? And so it was interesting. I had lots of advantages because I was in the ER and had hands and anesthesia was there. And this guy was 120 kilos at baseline. He wasn't a fun airway, but when you have massive airway edema from angioedema versus anaphylaxis, it is just not a fun day. And so we ended up attempting him a number of different ways and then ended up with a surgical airway. What was super interesting about him, and exactly to Paul's point, is he had so much edema in the floor of the mouth that it distorted his anatomy and his all of his landmarks here, right? And so we did the exact same thing. Like I had a plan, I was marked and everything. Because looking at this man, I was like, that man's gonna get cut today. Like I was like, this is a bad day from the very beginning. What was super interesting is all of the marking I did beforehand was completely and utterly useless because he progressed edema while we were trying for 20 minutes to intubate him. And luckily he desaturated, and then he desaturated to 70%. And I was like, okay, we're in, right? And so where we ended up kind of scrambling to, and so I think this is the other point of like these super high risk, low frequency procedures that we do, is like always have a backup plan to your backup plan, right? And I ended up actually myself, along with a chief surgical resident, ended up tracheing this man instead of criking this man on purpose, right? Because I do the exact same thing where I go bottom up for my landmarks. And so I was like, well, that is definitely trachea and he's still dying. So
Yeah.
here we go. And so luckily I had the advantage of a surgical resident that had done more trachs than I had, although this was her first emergent surgical airway. She felt a lot better when she walked in, and I said, I've done surgical airways and I feel comfortable. I just want you to assist. And she was like, oh, that makes me feel a lot better, right? But yeah, it was a terrible case. I've thought about it every day since. Hopefully that part goes away soon. But again, like you have to be prepared for all of the pieces that go wrong. And knowing, just eyeballing the patient, and like we intubate a lot of people and we don't cric a lot of people. And so having that mindset of at some point we will all do surgical airways if we have to. Not a I hope never to do this.
This was
Totally.
anaphylaxis. Maybe it shouldn't be a surgical airway, right? It
Yeah.
depends on what the situation is.
So,
Oh, yeah.
so actually, Tanner and Sam, before I get to Tanner and Sam and Tanner, this is the beauty of LinkedIn, because as this was going live on LinkedIn, I was chatting with an EM doc from Northern California who just joined us on here because this guy's written like textbooks on this stuff. So, Jacob, welcome. Tell us who you are, and thanks for joining us. And we'd love to hear your comments.
Hey, I was greetings to everybody from New York City. I'm kind of hiding out in my little room here because my actually sleeping. But anyways, I'm really happy about that. Everyone, somebody's actually running a webinar on this subject, which is tend to be a little bit esoteric in nature, as you know. I actually got interested doing crikes from Long Island. I used to work in Eastern Long Island Hospital, which became part of Stony Brook Hospital 5 years ago. We had a very bad case. Patient was like around 50 years old. He had a very bad angioedema. We scanned the guy right away to image the airway, and unluckily, the guy airway was actually closing. So during that time, being tiny hospital had a lot of backup. We had surgeon involved pretty quickly and anesthesia. And basically that one I didn't get involved other than being an attending, but I got everybody mobilized so we could get his airway, surgical airway done right away. And guess what? The guy was transferred to the regional center and he survived. But he didn't think that he wanted to actually go home. He wanted to sign AMA and go home. So that's more or less how kind of goes. A patient can be talking and they look stable, but they could be really closing. So what ended up happening after that, I moved to California to work, and I started writing a book on anatomical localization of a crike. I hope I'm not talking to myself here. Is anybody still?
No, we hear
I'm
you.
listening, sir.
Yeah, so what ended up happening is that, I was flying to California for a work contract for ER in Northern California first. And those 6 hours in the airplane, I have an ultrasound machine, and I start playing around with it. And I actually developed a pretty easy way to actually identify the cricothyroid membrane with ultrasound. Actually, it takes like 10 seconds to identify it. So obviously, in an emergent scenario, you are not going to have the luxury of the ultrasound. However, what actually the writing of the book helped me was not only we developed the ultrasound techniques to image the area quickly, but we also developed systematic palpatory practical anatomical techniques so you could identify the cricothyroid membrane much more confidently. Because the problem is that when this happened, usually a lot of the providers that they did not expect they have to cut somebody's neck. That's a reality. So the biggest problem is where to cut. You ask anybody, oh, can you show me where exactly to cut? And when you ask anybody, even a seasoned guy, they're gonna freeze up. I know this for a fact. Why? Because when I talked to a couple of other my colleagues, we actually discussed this. Look, when you have to do a cric, when you have to intubate somebody, do not be surprised that you may have to crack somebody because intubation can go wrong. Not because you are not a good intubator, but when you're actually looking at through the camera, the airway, you all of a sudden realize there is a major obstruction and you cannot negotiate that. So actually, I was pretty fortunate. I'm not saying fortunate or unfortunate, but last year I cracked somebody, 80-year-old lady on dialysis that went to cardiac arrest. So we are actually doing a code. But the respiratory guy said, oh, we cannot bag this patient, doc. So I have my own VL. So with the video laryngoscope, I quickly took a look, because one of the reasons why you want to crack somebody is you cannot ventilate the patient. And the other aspect of it, you cannot intubate. So the thing is that when he said that he cannot ventilate, and that's part of when we do the resuscitation, I put the camera in, the airway was actually closed with a tumor or something. You could not see the vocal cord. So I told staff, look, give me the scalpel because we need to, and a bougie because we need to crack this lady. And when I was about to do that, because I don't know this lady, because it was a rapid response, respiratory tech said, look, did you see her neck? Short neck, and there's a big tumor in the neck. So this was actually, apparently she must have some type of goiter or something, because when we are called on to see this patient on the floor, we don't know these patients. Same thing in emergency room. We don't know a lot of the patients that walk into our doors. So making story short, we had to localize the area. I had to estimate because she had a tumor, right? So very thick neck. She had a tumor. Anatomy was distorted. So we kind of do approximation using anatomical localization techniques. And then after that, I put the scalpel and I made an incision around 3 centimeters. She was on a heparin, so you imagine how much she was bleeding. And then I had to put my finger really deep in it, almost like a 2 centimeter or deeper. So first, the biggest anatomy, this is very important for anybody doing a cric. And a lot of courses don't emphasize this. If you want to be really good at doing cric, you have to be able to localize all the important structures of cric with the eyes closed. Why? Because when you're palpating the structure, it's a similar feeling. Your fingers will have to tell you what you are feeling. And the problem is that it sounds almost like a commando stuff, but And when I tell people this, look, you should be able to localize everything in the neck, articulate at least the 5 important structure related to cric that you should be able to articulate to me, and you should be able to point it out with your finger really well. Problem is, many times, many of the training programs, they don't really emphasize this because you have to do this first. You have to do these drills. Find the important structures with the eyes closed. You could do this on your family member. You could do this on your peers. This doesn't cost you anything. Actually, this is the best practice you could do because you are practicing on a live patient. You're not going to cut anything. You're not going to hurt anything. It's all about feeling with your finger the important structures. And what I actually learned, you have to start from the mandible. You have to grab the mandible really well, and then use your thumb, push it towards the head really hard. And the first structure you're going to feel is a hyoid. Very, very important because this is a reference point. Some doctors actually they get confused because they're under a lot of stress, and they confuse the hyoid with the inferior border of a thyroid cartilage. So now you're cutting too high. When you're cutting too high, you are going in a wrong spot, and you end up damaging the vocal cord. If you damage the vocal cord, patient may survive, but now you're sitting on a big lawsuit, right? So a lot of people may say, oh, but I saved the guy's life. Even when you do a life-saving procedure like cric, they expect you to do a very good cric. They don't want you to destroy something, and next thing you know, I saved the guy's life, but he cannot talk anymore. That doesn't work. Because recently in New York City, there was a lawsuit in one of the hospitals, the teaching hospital actually, in the ER residency. They ended up cutting too high. So first thing you got to do, grab the mandible. Train this, grab the mandible really well, because it's very visible right here at the chin. Grab the mandible, use your thumb, and push it up towards the head. And the first thing, the structure that you're going to feel is going to be the hyoid bone. After that, once you localize the hyoid bone, you're going to feel go inferiorly, you are going to feel a little dip. And after that, you're going to arrive at the superior border of a thyroid cartilage. That's the prominence of that is where the Adam's apple is. The problem is that a lot of training programs, they tell you, oh, localize the Adam's, slide down your finger, and if you feel the Adam's apple, then go down a little low, and then you cut. That's basically how we've been training everybody. And for me, that's a problematic thing, because if you tell somebody you're going to cut in the neck for airway management, and you're telling them, find the Adam's apple, that's actually very, very too simplistic in my view. I don't think you're going to understand what you're really looking at. So after you palpate, you find the hyoid bone, you're going to go a little bit lower, and you are going to the next structure that is more prominent, which is a major landmark, is a thyroid cartilage, right? Because it's a little bit larger versus many other structures related to the cric site. And basically, you are going to develop the idea of holding the body of the thyroid cartilage, and you are going to move gently side to side. You could do that in your own thyroid cartilage. When you do that, you're going to feel a little click, very, very gentle click. That's the only structures in the neck that you are going to feel this click. We call that laryngeal handshake. So you could click gently. So this way, you know, once you identify you're in a thyroid cartilage, and you could have a thick neck, but you could still actually do that because you could gently mobilize side to side. And then once you identify the thyroid cartilage very well and the body of it, slide down gently inferiorly, and you are going to reach the inferior border of a thyroid cartilage. And after that comes the cricothyroid membrane. So and there are a lot of palpatory techniques, right? There's other technique, for example, the trauma surgeons, what they like to do is they like to hold the hand like this, dominant hand, close your fingers like that, find the
4 fingers.
Yeah, right here. Yeah, exactly. And then rest the pinky in on top of the notch, and you bring it up like forward like this. And basically, the index finger is supposed to give you an approximate of the cricothyroid membrane localization.
Mm-hmm.
Interesting. Jacob, this has been fascinating. I wish we could spend more time. we're 9 minutes over, but can you put in the chat the vote if you wouldn't mind? And I want to bring in a few other people. So Sam, stay tuned for a second. Let me bring in Tanner. Tanner, I'd love to hear your comments, and we'll go to Sam.
Yeah, so just two really things. So first of all, Alan, I'd say you never have to apologize for taking multiple papers, pulling data from them, and combining them to make a point, right? The literature is a tool, and I think that you basically just demonstrated that you actually read the papers and understood what they were trying to tell you. So I'd actually give you additional kudos for that.
Appreciate it.
Um, so the second thing that I wanted to comment on is on your last slide there, you talked about incorporating into simulations scenarios where the decision not to crike has to be made and where patients can be temporized with BLS airway adjuncts, iGel, supraglottic airways. Locally, as we've been rolling out RSI trainings across the state, right, it's kind of a new procedure that everybody's excited about. And when the physicians leading these trainings have incorporated scenarios in which RSI is not needed, right, almost invariably, right, clinicians are jumping straight to RSI, right? So I wondered if you had any comments on, kind of how that's gone, if you've done that with your trainings. And I wonder, kind of how the epidemiology of crikes have changed now that we have, these second generation supraglottic airways like iGels that really do a good job even in pretty macerated airways. So,
For people jumping to treatments, I think it depends on two things: their comfort, like legit comfort of saying, "Hey, I need to make this decision," or their eagerness to do the thing because they said they did the thing. Um, in training, it's well, if they see the trainer on the neck, oh, I'm probably going to be doing a crike. And that's where we want to steer the conversation or the thought process of a clinical decision versus just, I see the trainer, therefore I'm doing it. And they usually end up gaming the trainer anyway, and it's just them going through the motions. That's also one of the things I see on the remediation side is like, don't game it. For RSI, my system does not have RSI. So I had one maybe 6 weeks ago, anaphylaxis, two EpiPens, IM from us, push dose from us, infusion from us, still not doing great. And that's where I'm like, well, I might have to make this decision and go ketamine and be writing a UCR for this, unfortunately. So in those scenarios, it's again, and I should have said this earlier, having people also learn what their tipping point is. What is my line of, okay, I'm going to this procedure now versus again having to convince yourself to it. Just like when we see anaphylaxis, hey, I'm giving them epi because I've crossed this threshold. Then for the different audiences, like military DoD, they don't really have intubation and they don't have eye gels because if they take an eye gel, they're probably going to be dead anyway. That's kind of what the new T-Tri-C guidelines have seen. So again, that's where it's like, hey, is recovery position going to work? How do they measure that? So it's again them working through the clinical problem versus just doing the skill and high five, I did the skill. Does that somewhat answer your question or answer your question?
yeah, absolutely.
Okay, thank you. And then what was
All
the
right.
point? I'm sorry.
So just in general, I don't know, in your trainings, do you regularly incorporate scenarios in which the patients can be temporized without having to crike? I guess is a
50-50.
Yeah, and that's I think it's a great idea. It's smart to have people think through why you shouldn't be doing it rather than, oh, there's a trainer in front of you, meaning we're doing it today, right? So let me bring in Sam, and then I'm going to put Jonathan, Dr. Applebaum on alert. I would love to hear your comments if you want to, but Sam, go ahead. Sam Neglia.
With regard to cadaver training, have you any experience, successful or not, with consciously creating a false lumen and having the trainees experience the difference in terms of palpation of a true trach versus the false lumen? I had that experience once in a cadaver, and I found it became a great teaching value.
False lumen, are you saying like for tissue where you have like a false track?
Yes,
Yes. So
yes.
this is something I've seen multiple times, and this is where I bias towards ET2 versus the Shiley styles because I've seen guys where, again, even uncomfortable with the skill, they will just jam it in there and create a false track with it, and they think they're in. And that's where you go back and verify. It's like, hey man, go through the steps. you're off. And even in like one of the recent MCRIT podcasts, thing is, Scott Weingarten and Dr. Levitan, they were talking about that specifically with, and even in some of those smaller shyly styles, they might dislocate on their own sometimes with movement, and then they false track that way also. So I have not created that. They usually end up creating it on their own.
Great
Great.
comment. Um,
Sounds good. Thank you.
Yes, sir.
Dr. Applebaum, are you there? Any comments you want to make? I maybe he's on maybe he's not listening. Okay. I wanted to make a couple more comments just because I wanted to show people after Casey's webinar. I went ahead and bought this kit. It's $300, right? And to your point, Alan, it's got the male and the female, and you could probably see the differences, and that's why they did that. And so thoughts on this trainer, and then I ended up buying this just to have it as well. You had mentioned that this is a 6.0, and for the female, the outer diameter may be 8, which may be larger than their CTM. Is that the point you were trying to make there, Alan?
Correct. It can be. That's where I'm a fan of cutting border to border because you're getting yourself more real estate with that. So even if you're not cranking the head back, like patient appropriate medical versus trauma or anything, this is where I also think parts of the trach hook have their value, or people like the trach hook because you're opening that space up.
Right.
I'll leave it at that. Yes.
Okay. And any thoughts on this device, the $300 device, or?
I like it. I hope for Gen 2, he makes it to where the flexion isn't, you have to pull it up, but you're able to rock it back or something where it can open up also. That's really the only
Right.
thing that I've seen that doesn't mirror.
Right.
But
Right,
for what it is, it's an awesome trainer.
right, but to Jacob's point, the handshake side to side, you can get that. You're right here that this cannot flex open at all. The CTM doesn't flex
Yeah,
open.
you can pull it forward, but you can't flex it back. But it has
Right.
a great thing for cueing that stabilization, like on the sternum, because where that blue case slides down, that's a good part where, hey, it's me anchoring, however you choose to hold the
Okay.
scalpel. Yep.
Yes. Yeah, I thought that they felt pretty good, and it's not 1,300 or $3,000. It's $300. Any other final comments? I see Dr. Lee. Dr. Lee, you've been practicing emergency medicine for many years. You also on the legal side of the house. You want to advise us? Have you ever seen any of these cases go bad enough where they ended up in court because of either lack of training, or any insight you can give us on that?
Well, I mean, everything we said, you just have to be prepared for it. The case I had was a angioedema in the ER with the ER doctor. And the problem, frankly, well, they weren't successful with the crike, but they delayed the decision to do the crike for so long that I think they were already screwed, with hypoxia. And so it was a bad outcome. So I think it's, a couple of things just on this. For me, it's just, if we look at our paramedics, we have a spread of people. Even if you take the officers, who are the ones that are probably, we have such a spread of people that we just have to train this over and over and over. So I really liked the way you parse this out in the beginning. So a lot of this is about getting the confidence, and knowing when to make the decision. But that just doesn't come with once or twice a year training. The other thing I liked is that I do believe that you can train by grabbing your partner at the station and just go over and over and over it there. And I think that, that should be required on a regular basis. The other thing I noticed on the last talk, I have been a big fan of the trach hook. I think that makes a difference.
Mhm.
And so I do like the trach hook, which you said a while ago, Alan. Just
That
Thank
great,
you.
great commentary. Let me bring in Dr. Wayne, who is reminding us that there's the NMSP Airway Precon. Marv, you've been involved in all things Airway. Show us your face, if you wouldn't mind. And
Well, I have. My first crike was in 1968, if it gives you guys any pause. And yeah, we had one cardiac surgeon that put every single patient before he went on bypass, instead of an endotracheal tube, they put a crike. And that was education for us. Of course, that was a different world and a different time. Couple of quick points. Point number one, you're going to do this almost 1 to 0 times in your entire career. If you think about it, we do a crike in our EMS system once every 8 to 10 years. Okay, so it's almost a never. If you don't think about it ahead of time, though, you'll never do it. 3, the hardest part is getting people to do it because everybody's so fearful. And medical legally, I did medical legal work for 40 years. And well, it happens. It's very rare. And the potential to save a life is greater. So I'll leave it with that. Fear is not a solution. So anyway, thanks everybody. Appreciate you allowing me to make a comment.
Absolutely. I'm gonna give Alan the last word. What I've heard here over and over again is put a training program in place that's not just a once a year or once every 2 year thing. Make it a routine that you're going through the motions mentally, using just a marker, using your partner at the station, making it male, making it female, understanding the tools that you're using, understanding the anatomy, how it works, how it opens, diameters of tubes, etc. So you brought a lot to the table here that we don't really talk about. But Alan, give us your last word. Take us away. Great webinar today, and I think a lot of people joined us today and stuck around for quite a while. Great topic. Take it away.
I appreciate you doing this, Dr. Intevi. I appreciate the engagement from everyone. I'd say the big thing for me and what I've seen is that low cost, borderline free, just getting your hands on people at the station, people on your crews, if you're on a team, people on the team, because again, everyone's neck's a little bit different. And once you develop that sense of touch and feel with that, like you would with IVs versus just, oh, I see a vein. I think that's the biggest thing is getting the confidence for the external cues. Because once you get that and you have the opportunities of actually like feeling through that, the rest of the procedure is not too crazy. And that's not meant arrogantly or cocky or anything. Because again, like we are saying, a lot of angina problems or anything like that. But that external part where you build the confidence and you know what the anatomy feels like, I think those are the most important parts.
Excellent. Very well said. Any other comments from the group?
Peter,
Go ahead, Dr. Lee.
just quickly, I just want to make a point. I've been thinking about a lot about, EMS system of excellence, and I grade our system. I think about where we are. Fortunately, we don't have bad cases every day to test us, but I think about, that I want, if another medical director came into my system, I would like for him to be able to walk up to every, let's say, lieutenant, who's our lead medic, let's say, and ask them how to do a crike, to show me how, and also to how to do a needle decompression, or probably a finger thoracostomy, and when to do it and what gear and equipment. The other one is probably OB emergencies, perhaps. But if you think about it, these are cases where if we don't get it right, we're playing for all the marbles. And so, so across the board, everybody needs to be able to do this without any, stumbling around, not knowing when to do it, so on and so forth. Even if they can do it, if they don't make the decision in time, that's a problem, So anyway, I just keep thinking about how I would like for you to be able to come into my system and walk up to any lieutenant and ask them that. And I think if you did that and that happened, I think you'd be impressed with our system and our performance,
Yeah.
because we have to save lives at the end of the day.
I mean, that's a great point. I think all of us would feel the same way. I would also, and all of us who have done medical expert work will tell you this, is that if they're going to do training, make sure you document that training, because what the lawyers will ask for every single time when they're deposing the medic, when they're deposing the medical director, they're going to ask you all that. And they're going to want to see files and logs and when it was done and how it was done and who did it and et cetera, et cetera. So even an opportunity is to take this webinar when it's up on YouTube and just put it up on your Vector Solutions, your Prodigy, put it up on Emerge CE, put it up on something so that people are watching it, and then do a program where you're doing the in firehouse training, and they can get on their system and record 15 minutes, an hour of training, because like Wayne says, this is for all the marbles. And when that day happens, like Charlie said, it happened to him just last week. Those cases are always at risk for becoming a legal battle. And as you all know, these are they take years sometimes. They can drag you through the mud, and you want to be prepared to say, here's everything I've done, all the training I have, without having to say, yeah, I remember watching a PowerPoint. To just get your systems organized so that everything you do that's training is documented. So great commentary. Alan, you're welcome back anytime. I hope to see you again at the next conferences, and thanks for all you do.
Yes, sir. Thank you.
For everybody, thank you, sir. The link is in the side to join Dr. Pepe's webinar. The CME was at the top, 21373. Let me type that in again. 21373. Just so you know, and I'd love to have any insight. We have so many people booked for the webinar that someone just emailed me today. It's like, hey, buddy, the next one's only in October or something, some crazy thing like that. So I'm not sure if we should be doing more of these or just backlog everybody. But you know, at this time we have a lot of people wanting to come on the webinar, and we don't have that much time. Jacob, you want to say something? Are you on mute? Unmute yourself. Jacob, we can't hear you. Unmute yourself. Still no.
Unmute. How about?
There we go. Gotcha.
Okay, so I appreciate you. I didn't realize you were having such a great topic in a LinkedIn webinar, and I appreciate it because I don't know you personally. Appreciate everybody putting together the lecture. Important thing is, unlike other people's experience, I had to crack somebody 10 days ago in LA. 39-year-old guy. I had to put a size 6 endotracheal tube. He had a complete obstruction of the upper airway on a camera. And I had to make a quick decision because he was deciding to 77. I said, give me the scalpel, bougie. And we actually put a size 6 endotracheal tube really quickly. And the gentleman survived. He was only 39 years old. So the thing is, you have to be really quick on this and don't hesitate, because if you hesitate, patient dies. Number two, last year I had the 80-year-old lady that had to cry. She actually didn't survive because she was already in cardiac arrest. And a month ago, I had to intubate an epiglottitis case in an emergency room in LA. So in reality, I don't know about other people, but I see these cases very often. And the idea is not about if you cannot intubate, you crack. No, that's not the indication. It has to be airway obstruction. You could verify with a camera, and then you cannot ventilate. So this is a classic criteria. You can't really say, oh, I hear some people try to trick somebody and they see the vocal cord on the camera. That's incorrect, because they're going to say why you could not intubate the patient, right? So that's one thing. And now regarding your model, the training model, I would not want to buy a training model that just have the bones only. The reason being, maybe it's good for just mechanical training on it. However, we need to have, I actually discussed it with some gentleman in Europe who runs a company who makes simulation mannequins. It has to be full body like a person, because you have to feel the blood, you have to feel the tissue, because when you cut, you don't get to the cric at one stage. You have to actually cut and dissect down. So that's actually a very important part of it. Like you mentioned about the false lumen. False lumen happens because you are not reaching the cric correctly. So that's why you need to have full model. I think for the EMS, they could put on a budget to buy a very high-end cadaver, some kind of training center, so everybody can come with like one Saturday, like a grab couple of bagels and donuts, and let's do a training of a surgical airway in one of this high simulation centers, because you can't just use a little model like that, because that would be very limiting. I mean, it's good just for self-practice, but in reality, when you're actually doing them, you need to learn how to dissect down.
We would love to invite you down to Florida if you want to. If you're here, we have conferences here every year. And it's funny. I trained in LA. I trained at the Children's of LA, and I can 100% agree with you that we saw some sick patients there. So either it's LA or something else. But we appreciate all you're doing out there, Jacob, and thanks for joining us. You're welcome to join any Friday at 11 a.m. We have great topics every week. And with that, I've taken 30 more minutes than I'm supposed to, but it was a great topic and I wasn't going to stop it. Alan, thank you so much. Tanner, Charlie, everyone for joining. Appreciate you guys. Join the link on the right-hand side, and We'll put this up on YouTube by the end of the day. Thanks, everybody.
Thank
Thank
you.
you.
Appreciate it.
Thank you so much. Appreciate it. Thanks, everyone, for joining.